Hello and welcome to part two of our discussion on the human heart. Here we're going to look at some electrical events and some heart sounds of this heart. Recall that we are slowing down and going in depth into the cardiovascular system. Recall that cardiovascular system has the job of supplying much of that tissue in the human body with essential nutrients and gases. We talk about how blood contains many important substances, and now we're talking about the heart and how it pumps those around. In part one, we discussed some structures of the heart and how those allow the heart to do its job. Let's go more in depth into what causes an actual beat, that actual contraction, and that requires some conduction, some electrical conduction within that heart. So this diagram is showing an abnormal reading on Looker's right. It's called an ECG tracing. And we're going to look into what might be a normal ECG tracing and what might be an abnormal one. Here's an image showing human heart. I'm unsure if that link actually works, but you could try that. Last section, we talked about how we have contractile cardiac muscle tissue. That's primary cell that's going to be based in the heart, and that has the job of contracting, and that contraction allows the movement of blood throughout the entire systemic circuit. So today we're going to look at some non-contractile cardiac cells, and specifically we're talking about nodal cells that are going to allow that heart to beat. We might also call these autorhythmic cells because they are self-excitable. That is, they repeatedly generate spontaneous action potentials that then trigger heart contraction. In other words, these autorhythmic cells act as a sort of pacemaker. They set the pace, and then the rest of the heart follows along and contracts along with that. It's important to have this beat all happen at the same time. And one way that we can get these cardiac muscle cells to contract at the same time is through the presence of gap junctions. So these pacemakers and these gap junctions make up a conduction system, and this conduction system is going to be a sort of route for propagating an action potential through the heart muscle. So let's look at what's happening at the pacemakers and these gap junctions. In other words, what type of special structures might be found in this cell to allow pacemaking. So by the way, notice that we're looking at some of these structures shown in Looker's lower left. And so these non-contractile cells, these autorhythmic cells, we can also call sort of nodal cells. These nodal cells are not the cardiac muscle cells that are doing the contraction. But these nodal cells, like neurons, have sodium-potassium pumps installed in the membrane. They're also going to have sodium ion leak channels and potassium ion leak channels. The purpose of that is going to be to establish and maintain a resting membrane potential. So this thing, resting membrane potential, is often abbreviated by RMP. And what we have is a greater concentration of these sodium ions outside of the cell and a greater concentration of potassium ions inside the cell. So these nodal cells contain calcium ion pumps that create a calcium ion concentration, and that's going to be more calcium outside the cell than inside. So we see on this slide, therefore, we have an inward movement of calcium ions. Additionally, these nodal cells contain voltage-gated channels, and these are going to include the slow voltage-gated sodium and voltage-gated potassium channels. So in other words, the sodium and potassium work concurrently to move in and out of the cell. Notice how, again, there's a change in these movement of the potassium ions, we have an outward movement of the potassium ions, and we have an inward movement of the sodium ions. That inward motion and the movement of the sodium ions is going to depolarize and then causing the membrane potential to reach the threshold. Let's go ahead and take a look at some pacemaker and action potentials of these specialized autorhythmic cells that are only found in the heart. Now, in a few minutes, we'll be talking about a certain location on the heart called the SA node, the sinoatrial node. This sinoatrial node is also going to be called a sort of pacemaker to allow the potential to move across the heart. So these SA node cells have this autorhythmicity. In other words, they're capable of spontaneously depolarizing and firing action potentials without any external influence. So that's why they are self-propagating, so to speak. Just like a neuron and a skeletal muscle might have action potentials, these nodal cells have action potentials as well. And the graph shown on this slide shows 3 events that occur in these nodal cells. Our first is going to be reaching that threshold. In other words, number 1 says pacemaker potential. Step 2 is going to be depolarization, and step 3 is going to be repolarization. The difference between the nodal cell action potential and those other action potentials is what causes the threshold to be reached. Nodal cells automatically reach threshold using slow voltage gated sodium channels. So we're going to get also a closing of these potassium channels. So in this process, the slow voltage gated sodium channels open, and this is caused by repolarization from the previous cycle. And then sodium slowly enters the nodal cell, and that's going to raise the membrane potential from its RMP value of negative 60 millivolts to its threshold voltage of around negative 40 millivolts. This reaching of this threshold voltage causes an immediate opening of fast voltage-gated calcium channels. So then what happens is the calcium ions rush into the interior of the cell, leading to depolarization. And we can see that happening in step 2 of the diagram. And then referring to step 3 shown in this graph, the voltage-gated calcium channels close and the voltage-gated potassium channels open, and this causes potassium to rush into the interior of the cell, leading to repolarization, in other words, step 3. And then the cycle repeats on and on. What this does is causes a sort of heart rate to occur. If the heart rate is about 75 beats per minute, then this entire process takes approximately 0.8 seconds. So then what we have from this is this pacemaker has inherently a firing rate of the SA node at about 100 times a minute. And that's actually a pretty fast heart rate if you think about it. So then we need something to slow that down, and we get down to around roughly 75 beats per minute due to stimulation from vagus nerve. You might recall that vagus nerve also has parasympathetic impulses. So this is going to be a parasympathetic impulse that slows this firing rate down. So in summary, when we talked about neurons in the nervous system, they're a little bit different than these nodal cells. These nodal cells reach their threshold spontaneously, whereas those neurons needed some sort of outside stimulation. And what happens here in these nodal cells is that it's due to the influx of the calcium ions that allows us to reach that threshold. So because these nodal cells have a sort of autorhythmicity to them, we get a conduction system to the heart. And this diagram shows that overall conduction system. I know the structures are shown in yellow as if they were true nervous system structures. They're slightly related, but again, do not think of these as actual nervous system structures. We're talking about specialized cardiac muscle cells. And these, again, do not contract. They actually have the job of conducting electrical impulses. So our discussion is going to turn to these four main components of the conduction system. That is the sinoatrial node, abbreviated as the SA node, the atrioventricular node, abbreviated as the AV node, the atrioventricular bundle, that's also known as the bundle of His, and then lastly we arrive at the Purkinje fibers. I'm going to sort of skip ahead to the spoiler, generally speaking, what causes these. I just want to kind of overview what happens. Yeah, here we go. So this slide serves as a sort of a depiction of how this impulse is spread across to those four structures. All right. Well, let's back up a little bit. Let's take a closer look now at this conduction system of the heart. Let's peruse those four structures. As we've already mentioned, these autorhythmic cells fire spontaneously. Our first section, the SA node, is located in the posterior wall of the right atrium. This is going to be adjacent to the entrance of the superior vena cava. These cells initiate the heartbeat. Thus, it is a sort of quote-unquote natural pacemaker of the heart. And what this is also going to do is set a sort of sinus rhythm, so to speak. This sinus rhythm begins heart activity and spreads to both of the atria, and then the excitation is then going to be picked up at the AV node. So this AV node is located in the floor of the right atrium, between the right AV valve and the opening of the coronary sinus. And so we're going to get a sort of delay, and then it's going to transmit a signal to the bundle of His. As we arrive at the bundle of His, also known as the atrioventricular bundle, keep in mind this is going to be between the two chambers, the two ventricles of the heart. So this bundle of His extends from the AV node into and through the interventricular septum, as we call it. And then this bundle of His is going to divide into left and right bundle branches. Lastly, we're going to arrive at the Purkinje fibers. And these Purkinje fibers extend from the left and right bundle branches from the apex of the heart, and these continue through the walls of the ventricle. And then what happens is that this electrical impulse moves through the Purkinje fibers, and that's going to cause the ventricles to contract. In this slide, we have a comparison of action potential shape at various locations. So notice on the y-axis of this graph, we have the pacemaker potential, and then on the x-axis of the graph, we have time. And time is measured in milliseconds. We start off in purple, showing the SA node, and again, that SA node is setting the pace. And then from that SA node, recall that we're moving down towards that AV node. We're going to get a slight delay. We're going to get this 50 millisecond excitation spreads through the atria and down to that AV node. So this, in other words, is going to give a slight contraction to those atria. And the delay at the AV node is due to smaller diameter fibers. And that's going to allow for a better contraction of those atria, and then those ventricles sort of passively fill with blood. And then in 50 milliseconds, we get an excitation that spreads through both ventricles simultaneously. Again, this would be correspondent with those Purkinje fibers near the apex of the heart. Let's turn our attention to rhythm of conduction system. As mentioned earlier, that SA node fires spontaneously, roughly 75 times per minute, thanks to that input from vagus nerve. And then this AV node has an inherent rhythm of about 40 to 50 beats per minute. So then, what might happen if both nodes are suppressed, then fibers in the ventricles themselves fire only about 20 to 40 times per minute. So this creates a sort of difference between the nodes, and this can be challenging. But this is why the SA node needs to set the pace, because the others cannot set their own pace. So in other words, if the SA node is not functioning, the AV node becomes a sort of quote-unquote default pacemaker, and then the AV node is then going to establish the rhythm of the heart. This is possible because the 40 to 50 beats per minute is just about enough blood to sustain life. But this is not an ideal situation, so we need to bring in an artificial pacemaker. In other words, an ectopic pacemaker. The external pacemaker can give these extra beats that lead to the heart performing better and more active, delivering more oxygen to the tissue where it needs to go. So for example, one way we might have an ectopic pacemaker is caffeine and nicotine. In other words, we see that sometimes the side effects of these chemicals are an increased heart rate, and specifically caffeine and nicotine are going to inhibit cyclic AMP breakdown. This diagram shows an external conduction maker, in other words, a pacemaker. And again, this is due to a homeostatic imbalance, so to speak. So notice in this diagram, implanted beneath this gentleman's skin is a pacemaker of about that size in the diagram. And here we see that the wires then extend into the heart. We might get something called sick sinus syndrome, and that would be from an abnormally functioning SA node. So we're going to get arrhythmias, in other words, irregular heartbeats. What might cause afterwards then are fibrillations. Fibrillations are where that heart is going to have abnormal contractions. It's not going to follow a normal ECG tracing when we take a ECG printout. A homeostatic imbalance might be heart block. Heart block results when there's damage to that AV node, and that damage is going to interfere with the spreading of the signal to the other ventricles. In a few minutes, we'll talk about an ECG tracing showing heart block. Let's change gears now a little bit, and we'll talk about autonomic innervations. What sort of connections happen to this heart that is going to either speed up or slow down that heart rate? So we just got done talking about how the heartbeat is initiated by that SA node on the heart. Then the heart rate and the strength of the contraction are actually regulated by the autonomic nervous system. And in this diagram, we see it's innervated by the cardiac center within the medulla oblongata. And then also, as we mentioned earlier, there is vagus nerve. In a review of the nervous system, you might recall we have a region in the brain called the brain stem. And in the brain stem, we have a structure called the medulla oblongata. So this cardiac center is located in the medulla oblongata, and it has two regions. It has a cardioexcitatory center and then a cardioinhibitory center. This cardioexcitatory center functions using a sympathetic nervous system, and the cardioinhibitory center functions using parasympathetic nervous system. You might recall that sympathetic innervation is a sort of quote-unquote fight or flight response, whereas parasympathetic response is a sort of quote-unquote rest and digest or relax sort of response. So this cardio-inhibitory center synapses with the right and left vagus nerves, which then in turn synapse on the SA node and the AV node of the heart. Right vagus nerve synapses with the SA node, whereas the left vagus nerve synapses with the AV node. Let's look at another diagram that might show these pathways a little bit better. Here we go. We left off talking about the medulla oblongata containing a cardio-inhibitory center. So we also might recall that cranial nerve number 10, vagus nerve, releases parasympathetic innervation. And this parasympathetic innervation is going to decrease the heart rate, but has no direct effect on the force of contraction. And then sympathetic innervation arises from the cardio-acceleratory center and travels to the heart via the cardiac plexus. Neurons from segments of the thoracic spinal cord extend into the SA node, AV node, and the myocardium. Sympathetic stimulation to the heart increases heart rate and the force of contraction. And so in other words, it's almost like a gas pedal on, gas pedal off. Notice we can use keywords like inhibitory, meaning like a slowing down, acceleratory, sort of meaning a speeding up. Let's now turn our attention to electrocardiograms, ECG, formerly called EKGs. This ECG detects and measures the charge, that is the electrical activity in the heart. And we can see that this gentleman in upper right has electrodes hooked up to him. We call those leads. And we can see that there's a machine putting out a sort of graph, an electrocardiogram. The ECG provides a sort of composite tracing, I suppose, of all the cardiac muscle actions. And since the tracing measures action potential activity, we see a certain printout of that action potential. So on the y-axis of this graph, we're going to get millivolts, and on the x-axis, we're going to have time, measured in milliseconds. And again, this could be very similar to the graph we just talked about earlier about individual action potential. We have different types of placements. Often paramedics or first responders will put these leads, these electrodes, in different arrangements on different portions of the body to give different readings of information to help them diagnose the condition of the heart. Let's take a little bit closer look at that electrocardiogram tracing. We first see on this diagram there is a P wave. That P wave is our first sort of bump, our first deflection off the baseline, so to speak. And then we get a QRS complex. That's going to begin at the Q, it's going to end at the S, and we're going to have a very large peak, a very large deflection at the R. And then lastly, we're going to get a T wave above the baseline. In summary, these waves indicate the electrical changes associated with depolarization and repolarization of specific heart regions. Let's take a little bit closer look now at what's happening in each and every one of these structures on the ECG reading. These peaks, that the first deflection, the P wave, is analogous to the SA node having its atrial depolarization. In other words, at that P wave, the atria are having their slight contraction. After that P wave, we get to a P to Q interval, and that's going to be the conduction time from the atria to ventricular excitation. And that means we then arrive at the QRS complex. That's going to represent ventricular depolarization. In other words, the ventricles are contracting. From there, we arrive at an ST segment, and that ST segment represents the myocardium, in other words, the heart muscle, being depolarized, specifically around the ventricles of the heart. Lastly, we arrive, we can see a QT interval. That's going to be defined as the beginning of ventricular depolarization till the end of ventricular repolarization. So in other words, and by the way, it repeats cycle after cycle. Let's see. So what we get then is a sort of pattern. Notice how on the top of the diagram we're showing the conduction system in the heart, and the bottom part of the diagram we're showing the pathway along the ECG tracing. So here we have our pacemaker, the SA node, setting the rhythm, and that electrical impulse travels through those atria and gets picked up at the AV node. AV node then travels, sends that electrical impulse down the bundle branches, the bundle of His, so to speak. Recall that this electrical impulse is what's going to make those ventricles contract. And when those ventricles contract, we then need to go through a relaxation phase. That repolarization is shown there at the T wave. Here again, we have that summarized side by side, the ECG tracing and the activities shown in the heart. So in summary and as a review, we see that the P wave represents the depolarization of both atria, and again that's shown in the upper left, and then this electrical impulse moves over the QRS complex, and again that QRS complex is going to represent the depolarization of both ventricles. Then lastly, the T wave represents the repolarization of both ventricles. What else is there to say about this? Perhaps if the PR interval is prolonged, that might represent a type of heart block. And also, it's noteworthy that the ECG is a fantastic diagnostic tool to examine the heart's electrical activity. Since the ECG only examines the electrical activity of the heart, keep in mind that some abnormalities of the heart cannot be detected by ECG. But here on this slide, we are showing some abnormalities that do get picked up by an ECG tracing. For comparison, in upper left, we have a normal sinus rhythm. Again, take notice of the P waves, the QRS complexes, and then the T wave as it repeats along that baseline. In image B, we see an example of an abnormality called junctional rhythm. If we take a close look, the P waves are absent on that diagram. And this is because the SA node is non-functional. And because this SA node is non-functional, the heart rate is then set by the AV node, and that ends up being about 40 to 60 beats per minute. On the lower left-hand corner, we have a second-degree heart block. We see that some P waves are not conducted through the AV node, hence we have more P waves than QRS waves. And so we can specifically see that in these locations where there's sort of two bumps together. So for example, this is going to be, I don't know if you can see where my pointer is at, but you can see that we have our T wave there. Here should be a P wave, and it's prevalent, but it did not get conducted through the AV node. So notice that the QRS complex is absent, and also the T wave is. The next cycle does show a P wave, a QRS, and a T, but then the cycle after that shows a P wave again that is not conducted through the AV node, therefore QRS is absent, and so generally speaking we see a ratio of about 2 to 1 in this second degree heart block. And then lastly, we see ventricular fibrillation shown on looker's lower right. This is a chaotic, sort of grossly irregular ECG reflection. And this is going to be a chaotic form of action potentials within the ventricles. We also have atrial fibrillation as well. And this is going to lead to some serious disturbances in that cardiac rhythm. We now turn our attention to heart sounds, auscultation. In other words, listening to the heart. And the tool of trade for this auscultation is going to be the stethoscope, as shown in Looker's right. When we listen to a heart beating or a heart having its sounds, or when we are auscultating, a big misconception is that the thump we hear is a contraction of heart muscle. That's not the case. Normal heart sounds are caused by valves closing. The lubbed up sound we might hear in the heart is due to the first atrioventricular valves closing. That would be our lub sound. And then the semilunar valves closing, the dup sound, is sort of produced. So there are certain areas on the chest where we can place this stethoscope to best hear an individual valve closure sound. Notice that the sternum sort of creates a difficulty, but at the same time, of course, the purpose of that sternum is to protect the heart. So in other words, I guess what I'm trying to say is we need to sort of listen around the margins of that sternum to get a good listen to the valves and how they are functioning. So let's see. We'll start out with the tricuspid valve. This tricuspid valve is best heard at the end of the sternum, just around the fourth intercostal space. That would be at the right sternal border. And then if we wanted to give a listen to the bicuspid valve, aka mitral valve, we're going to hear this at the apex of the heart, and that's going to be at the fourth intercostal space, right about the mid-clavicular line. If we would like to have a listen to the pulmonic valve, that's going to be best heard at the second left intercostal space. That's going to be at the left sternal border. And recall, when I say left and right, we're talking about anatomical left and right, the patient's left or right. And lastly, if we want to listen to the aortic valve, that's going to be best heard at the second right intercostal space and the right sternal border. Sometimes we get abnormal heart sounds. We might get murmurs. Murmurs are generally caused by abnormal activities in the heart, but are sometimes actually not associated with any pathology. These murmurs are caused by turbulent blood flow around the valves, and that could be due to some abnormal anatomy, or maybe aging, or maybe increased volume flow. As mentioned earlier, not all murmurs are abnormal, but most indicate some sort of valve disorder. And again, I'm unsure if this YouTube link works or not, but in lab class, we have a closer look and listen to some of these heart murmur sounds. So we might listen to certain abnormalities. We might get something like valvular insufficiency. That's also going to be called valvular incompetence, and that's when one or more of the cardiac valves leak because the valves do not close tightly. We also have sort of valvular stenosis. That's going to be a scarring of the valve cusps such that they become rigid or partially fused and cannot open completely. And that does it for part 2 of the heart. We have one more part we discuss in this section, or in this chapter, I should say. Part 3 is going to be talking about cardiac output and the cardiac cycle. Looking forward to that moment. Talk to you then.